Welcome, everyone. Grateful to have you all joining us for our Big Ideas in Mental Health panel discussion. Today, we're going to be talking about grief, bereavement, death, and dying in Nova Scotia, which is to say in unceded Mi'kmaq. And we are very grateful to have you all here. This does count towards one of the mandatory social justice requirements because it is something that emerged from our Social Justice Committee, as I will share in a few moments. But first, we want to just take this moment to begin with a land acknowledgement. So please join me in the chat and acknowledge the name of where you are joining us from. Placenames.mapdev.ca is one website that you can go to that's interactive so that you can figure out the specific name of where you are joining us from. And if you have a window, you might want to look outside to connect to the land, or close your eyes and think of a place where you feel especially connected to the land. Perhaps it is your garden, perhaps it's a walking trail or the beach, but just take a few moments to feel connected to the land and feel that gratitude. And then please join with me in this land acknowledgement. I would like to begin by acknowledging that I am speaking from Unama'ki, which is located on the ancestral and unceded territory of the Mi'kmaq, whose inherent rights were recognized in the peace and friendship treaties that were signed with the Mi'kmaq, Maliseet, and Passamaquoddy peoples from 1725 to 1779. This series of treaties did not surrender Indigenous land, resources, or sovereignty to the British Empire, but instead established rules for an ongoing relationship between nations. The treaties were later reaffirmed by Canada in Section 35 of the Constitution Act in 1982, and they remain active to this day. Let us take this time to pause in reflection and gratitude for the land where we live and work. And as we pause in gratitude, let us also pause in gratitude for all who have and continue to heroically care and advocate for this beautiful land. May we join them in this sacred work. Let us ground ourselves in the wisdom of the land-based Mi'kmaq teachings and values that we must all begin to learn. Let us work to decolonize ourselves, our practice, and this community that we share by working for justice for all living beings as an expression of our gratitude for being here. Let us take a deep breath and recenter ourselves away from the violent ways colonization fills our world and fills us. Let us take a deep breath and work on letting go of the unconscious bias that is everywhere, inside and out. May our session today lead us to be in right relationship with this land and with one another. And when we acknowledge the land, we must also begin to acknowledge the wisdom of this planet and align ourselves with its truths. We are all treaty people. So how does this impact what we do and how we do it? And how will it guide our work together today? The Nova Scotia College of Social Workers commits to translating this acknowledgement into action by seeking to implement the recommendations of the Truth and Reconciliation Commission's calls to action, especially those regarding healthcare and education. We commit to doing what we can to becoming better treaty partners. We commit to learning and to unlearning. Decolonizing ourselves and our practice means recognizing the ways in which we are each impacted by the colonial system in which we all participate, and from which those of us of settler descent continue to benefit. Each of us, depending upon our social location and intersectional positionality, are uniquely impacted or oppressed. For example, those of us from African descent were dispossessed and uprooted from their land and brought to Turtle Island against their will as part of the white supremacy and slave trade that fueled the settlement of this continent. We take this moment to reflect upon the unique impact of colonization upon each of us and upon our practice. And we commit to using our professional development to both learn new ways of thinking and understanding the work we do, and to unlearn assumptions and bias, so that we can ensure safer social work practice in a more just world for all people. We are grateful for the new Canadian Association of Social Workers Code of Ethics that requires us to shift from the illusion of neutrality to becoming actively anti-racist and fighting against racism and all intersectional prejudice that is part of colonization. This is how we ensure safer social work practice for all. And this is at the core of our Big Ideas in Mental Health panel that we are hosting today. It is born from the Repositioning Social Work Practice and Mental Health report that we did a couple of years ago by our Social Justice Committee. And in that report, we saw that 98% of our social workers working in social work practice believe that there need to be changes made to the current provision of mental health services in order to address some of the larger structural issues that contribute to mental health and that are not yet currently addressed. And so today's panel reflects that. Our Big Ideas panels that are counting towards your mandatory social justice requirements are part of our efforts to advocate for the psychosocial and structural determinants of health. And our ideas are to really help foster collaboration and to prioritize family-centered practices and to advocate for increased resources to address the inequities that affect the determinants of health and limit access to existing services, as well as the ways in which existing services are not yet meeting all of the needs for well-being that we understand. As social workers, we understand the intersectionality of micro, meso, and macro practice. And we believe that it's important to hear multiple voices in order to better understand complex issues. Some of the systemic factors that feed into mental health may not be apparent to everyone in the same way. And it is therefore our goal to integrate research and practice with the wisdom of first voices to better understand systemic struggles and the strategies that we can use collaboratively to build a better world. And so with that, we are very grateful to all of our speakers today who are going to help us understand this issue. And we are going to begin with Jacklyn Paul, who will share some thoughts.
Hi everyone, my name is Jacklyn Paul, and I am a Mi'kmaq social worker from Sipekne'katik First Nation, and I'm very honored to be here with you virtually today to discuss important topics such as culturally safe supports in mental health and death and dying from a Mi'kmaq perspective. Because of the time, I'm going to jump right into it. So I think we first have to be mindful about how hard it is to reach out for services, and we all know that. But not only is it difficult to do so, with that being in mind, it's even more difficult when the message has been you can't trust anyone. So when someone comes into your office and they tell you, I see and communicate with spirit, does your practice allow them to express themselves in a way without being labeled client is delusional? So this is a experience of a community member who had sought out help, and when asked to read the notes from the session, had seen this written down. And so that was the last time that they reached out for help, and it immediately caused a shutdown. And so that experience is shared and it's told to someone else. And what happens is sometimes people still do come for help, but knowing that you're going to be judged or knowing that you have to hide pieces of you doesn't allow for us to build that therapeutic relationship that we need to start breaking through multi-layered traumas. And so I really want us to just think about how we think about spirit and people presenting with that information. I also wanted to touch on when it comes to death and dying from a Mi'kmaq perspective and experience, and how we process death. Our communities, we all know each other. And not only do we just know each other in community, but we know each other in other communities. And so when other communities are hurting or have someone pass, we grieve for them as well, because we are moving together. We're seeing each other at Maui-Omis. And so we experience a lot of death, and how we have to be able to process that is a bit different. But we also know that our loved one has begun their next journey, and that there is no end, and how we will connect is through spirit, which was why I made the point about the counseling session. And if someone is presenting and say that, you know, spirit is important to them, because it is really the essence of everything. We believe that everything has a spirit. When it comes to being in a hospital, and there are policies around how many people can be present in the room during our family's final moments, it really causes a lot of turmoil to have to identify who can be in the room, who is allowed to be present, because everybody wants to be there. And it's also very difficult for us around policies that say only family can visit, because our lived experience, our version of family is so much broader, and so it doesn't always quite fit for us. Also, we come from really big families, and when we're dealing with someone in their final moments, or our family is in the ICU and we're being questioned, can all of these people actually be your uncles and aunts? They are. And to be in that position and to made feel like you're lying about that, it's just that extra layer of shame or burden that we bring to the space. And so that's really difficult, because we do have big families. So not only is family just trying to gather and cope and process with what's going on, but we're away from home, and we're away from community, and we're looking to build that in an urban setting where smudging is never permitted and drumming is not allowed unless it's done outside. And we rarely have access to an elder or a traditional person to send our loved one off in our own way. And I believe that this is a position that should be staffed permanently and 24/7, because people don't die between the hours of 8 to 4. And so not having that available is something that really sits with you. One last thing that I'd like to mention that Indigenous families really struggle with is also the visiting hours. So that concept that you can't see your family, but you can only see them between, you know, certain hours, really feels inherently wrong. And I say this because you may or may not be aware of this cultural practice, but when our loved one actually passes and starts their next journey, when we bring our loved one home, we wake them in our house, and the community comes and pays their respects. And there's a sacred fire that's lit, and it continues to burn, and it's never alone, nor is our loved one in the home. Our family and friends stay with our loved one the entire time they are in our home. And so that's why I wanted to mention that we never ever leave them alone. And so the visiting hours is extremely difficult. And we're hoping that we can start to have conversations about just being able to take space and be in the room, even if we're not allowed to say a word. It's more about that spiritual connection and staying with our loved one. Being together is really where we draw our strength from. We lean on each other to provide different types of support, as any family does. But it's not meant to annoy staff or create more work for a very hardworking, a very overwhelmed system, but we have to do better on bridging the gap between what exists, what is accessible, and what needs to happen around decolonize our thoughts around death and dying and people gathering. I want to thank you for sharing this space with me and hearing me out from my own lived experiences. Ellen.
So with that, take a moment now. We're going to have a chance to hear from Hallie. Hallie, thank you so much for joining us to share a little bit more from your perspective.
Thank you, Nash. Yeah, I just wanted to share some of my experience of when my mom was very sick before she passed on. As a Black and Indigenous woman, I see death in a very similar light to the previous speaker, but I also see it in as part of the Black culture. So me and my siblings were in the room. My mom was in ICU. My siblings were in the room with me as we decided that
There's love being sent to you in the chat right now. And we know this is a very painful conversation.
we decided that we were going to pull the plug, but much like my mom was in life, she was outspoken and people were not going to tell her. Before we got to pull the plug to let her go, she decided she was going to do it. And as we noticed and saw her oxygen level go down, we sang her favorite hymn. We looked at each other. We knew what needed to be done. As she was going on her next journey. So we sang gospel at the top of our lungs. We were in ICU. I recall there was a nurse in there that said, "Shh." I looked past her. I didn't care because I knew what my mom needed in order to ascend and go to her safe journey. So as we were singing her favorite hymn, "His Eye is on the Sparrow," we sang so loud that I remember person come and shut the door as we were in a spot. And it's because there is no multiple understanding of death and dying, and that singular narrative that has, again, to echo the words of the last speaker, that it's spirituality, it's connection, and it's community. So saying that there's only one person allowed or two people allowed in ICU, that they have to be biologically connected, that there's a time frame. There is no time frame. I understand passing over, and as we call it, a heavenly homegoing or homecoming, is the way that we show respect. My relationship with my mom never ended. It's still hard. Asking somebody how long it's been since your mom or your parent or your loved one died, that has no relevance. That relationship never ends, and it still has an end, and it's over a decade. As you can see, it still affects me. So we need these systems to be responsive in a positive way and not understand death in such a linear, rigid fashion that causes more harm and more heartache to the families who are already deeply affected by the passing of their loved ones. I hope that this talk, in terms of being there and actually meeting people where they're at. I know we say that as social workers and people in healthcare, but really meeting people where they're at. And that means understanding that Blacks are not a monolith. My experience might be the same, might be different. You know, I have multiple intersectionalities, and based on that, ask me what I need. What would have been helpful is to have a room separate, maybe smudging in there. As I said, I'm also Indigenous. I've really come to understand what that means because I was never afforded that opportunity. When I was young, I could understand why my grandmother, who's Black, also didn't want to say she was Indigenous. She was already being ridiculed for being a Black woman. So I just wanted to leave my reflections with people who are supposed to be helpers. Please be helpers. Please listen. Please be responsive and not reactive. Please be proactive and be the change that you want to see and the change that is sorely needed within these healthcare and other systems. Thank you. I think that's all I have. Thank you so much.
Thank you so very much. And I hope that you are able to draw some strength and love from the hearts that are coming your way and the love in the chat as you thank you for sharing some of your experience with us to help us understand that we need to rethink the way we are currently talking about death and dying. Mary, Ellen, so grateful to have you here to share some of your thoughts on this topic.
Thank you to the two previous speakers. Thank you so much, Hallie, for sharing that story. Jacklyn, for sharing your wisdom. I'm here as a Dalhousie professor. I'm a researcher. I'm a death and grief scholar. And I'm a griever, like probably everyone around this Zoom call today. Humans, we grieve things. My entry points into this topic come from both the personal and the professional, and I really appreciate, Naj, your offer to frame our remarks from our social locations, because I believe we really need to lead with the personal in the realm of death and grief to ensure that we stay rooted in what we share as humans in and across our diverse communities. So my entry into this conversation is as a griever. I'm living multiple and compounded griefs, some from human death, some from animal death, and some less tangible and more kind of existential losses. And I wear my grief as a second skin, both kind of proudly as well as poignantly and tenderly. And I've learned in my experience and my research, talking to, fellows along the way, and also in my scholarship, that you can't leave it behind. And this teaching helps me carry it better. But to paraphrase the song, just because I carry them well doesn't mean they're not heavy and that I don't need help. So professionally, I come with 25 years experience in the realm of pediatric and adult palliative and hospice research. I'm an anthropologist, and my job has always been to try to make the familiar strange. That is, to see what has become normal and acceptable or accepted and familiar in our cultural and social worlds, and to see it as familiar, but make it strange so that we can unpack it, we can critique it, and then we can try to reassemble it together in new and innovative ways. And I truly believe that palliative care does have its heart in the right place, but it tends to be in our healthcare systems that often do not. There are so many counter forces in our kind of formalized, institutionalized healthcare contexts that mute, transform, hijack dying, death, and loss in ways that do an intense disservice to our patients, families, grievers, and communities, both small and large. And we just heard 2 examples of that in the prior talks. The whole idea of a visiting hour, no, families are not visitors. Families are families, they are not visitors. And I loved Hallie's image of gospel in the ICU. Yes, we need gospel in the ICU. I firmly believe that dying, death, and grief cannot flourish in our current institutions. And maybe flourish sounds like a strange word for grief and death, but I do believe dying and grieving needs to flourish socially and culturally. They need to be celebrated. We need social rituals to help us mark these events and experiences. We need to embrace dying and grieving as fundamental elements of living well. Death and grief are both large, generous, expansive experiences, and we miss out on so much by tamping them down, closing them behind opaque and often medicalized ICU doors, as we heard Hallie speak about. I think public and community health and well-being frameworks are more useful for imagining a world in which dying and grieving do not need to be overly enmeshed with clinical versions of mental health. I think well-resourced death literacy and grief literacy can help us decrease the risk of complicated and prolonged grief and improve how people live their end of life and how grievers are supported within their communities. Thank you.
Thank you so very much. Very grateful to have your lived and professional expertise joining us. And now very grateful to have Jocelyne, who is here to share a little more about all of this. Thank you so much, Jocelyne, for being here.
Thank you for inviting me. I am going to just speak from my heart for a few minutes. I come to this conversation, my professional role is as the bereavement coordinator with the palliative care service. That's in Central Zone, but very much with Mary Ellen's words in mind is, I'm also bringing my whole self. And so I am coming to you. I'm a social worker who's worked in the healthcare system now for about 10 years. I have, as Mary Ellen said, multiple and compounding griefs of my own. And the one that I want to bring forward to the group today is the griefs that healthcare providers themselves are experiencing. And it's been talked about in Mary Ellen's conversation. So Mary Ellen, Dr. Mary Ellen Macdonald is what I like to call my academic counterpart, but certainly somebody who I greatly respect and connected to the palliative care program. And her and who she works with together around the ideas of grief literacy is something that I attempt in my position to implement. So most of my work, or much of it, is with grievers. So after the death has happened. But now at this point, I also just going to close off. I just got distracted for 1 minute. Thank you for bearing with me. Also is to bring grief literacy to my fellow healthcare providers. So I do that by hosting grief literacy conversations for healthcare providers. And a lot of what that is about normalizing grief, about bringing the principles of grief literacy and saying that, you know, we ourselves as healthcare providers, for those in this audience who are a part of this, we are bringing our own griefs. And we are in a healthcare system that, as Mary Ellen outlined, makes people grief and trauma more difficult. And certainly all the speakers have spoken to the eloquent examples of how it's caused harm, how our system causes harm. And that causes harm for us to be in that healthcare system, us as healthcare providers. So acknowledging grief, I think, is a really important place to start, and to have opportunities where, as people who are working in these dehumanizing systems that harm people and are a part and parcel of people's deaths and griefs being much worse than they needed to be, that we ourselves are grieving and need to talk and have opportunity to have that validated and be given some language to talk about it that isn't about specialized clinical language that are for special experts, but it's for all of us, because grief is a human condition. I just simply have the privilege of getting to spend my full work days engaged with the topic of grief. So I think, you know, that's what's coming to my mind right now. What I feel I can contribute to the conversation is about the need for the healthcare providers and those who are in the front lines of working with these dehumanizing systems to be able to have spaces to have our own griefs validated and become, ultimately, with the goal of grief literacy, more compassionate workplaces and more compassionate place for all of us. I think I'll end there. Thank you for inviting me.
Thank you so very much. Very grateful to have you sharing some of your story and perspective, and really how powerful for us to reflect on the ways in which our current conversation around burnout and staff, we are not really talking yet about the ways in which so much of that could be potentially resolved because of the ways in which we have our own inner conflict with the jobs that we are assigned to do, working in a system that does dehumanize and does not recognize the holiness and spirituality of death and dying. We're going to have a chance now to hear a little bit from Justin, who's very marked by the spirituality of death and dying.
As we approach end-of-life issues, as we approach how to care for people, there's just a lot of hesitancy and a lot of lack of understanding about how to really engage, get the services people need, get conversations that need to be had, and really try to honor that as a process that sees death as part of the life cycle, not something to be, the language falls apart here, because it's not that I don't want people to not be afraid. I can't really dictate that, but how we do it to where there is some kind of connection across that threshold, whatever that threshold is at the end of someone's life, realizing that it really is a significant time of change and transformation. And what it feels like is it's very fragmented and avoided. And so as I've done a lot of my education since my father's died, I've started looking at what could be done, because it's not just a workshop. I used to think that we would have just conversations about this through something. I started hosting something called a Death Cafe in 2014. I thought that the conversation would be the piece that would make the transformation. Rather naively, I have again started hosting broader conversations with different focuses in 2016. I'm engaging different audiences, bringing together different voices, trying different mediums, including art, poetry, movies, books, things like that, and realizing that the conversations are helpful, but in terms of creating meaning and creating change, there are some much deeper threads that sort of need to be addressed and need to be tended to, and I don't know what that exactly looks like. I can say that for myself, I've probably had, other than my own life lived experience, the hospice patients that I've served, I would say that some of my main teachers have been through books, but also I've had really the privilege to study with several people in person. Joan Halifax, who Haya Zen Center in Santa Fe, New Mexico, Frank Ostaseski, who co-founded the Zen Hospice in San Francisco, Stephen Jenkinson, who is the founder of Orphan Wisdom, who lives somewhere near Toronto in Ontario, and then Bernie Glasson, who was a Zen teacher who really did social engagement around different areas of suffering. And I feel like as I move forward, I'm currently in a lay ordination process around community lay ministry in a Zen Buddhist tradition. And I feel like that piece of bearing witness to suffering and being able to have compassionate action rise from the people who are involved is going to be part of this. I think there's going to be an intersection here with lots of different professionals, lots of different points of view coming to the table to be part of that bearing witness. But what comes out of that, I am not sure.
So grateful to Justin, who has done a lot of advocacy around the idea of death cafes, and is always trying to keep growing and learning and expanding our conversation around this. We now are going to have a chance to hear from Kim Gariepy, who is a social worker with SchoolsPlus. Will share a little more of her perspective. We worked with SchoolsPlus and the school system a year and a half ago. Serena Lewis, who many of you know and who's going to be here to speak in a little bit, did a 3-part training for school staff on how to address death and dying because it's such a huge need. So we're grateful to have Kimberly speak a little bit.
Hi, my name is Kim Gariepy, and I'm a SchoolsPlus facilitator with Halifax Regional Center for Education. So through my role, I cover schools mostly in the downtown Citadel area. So the schools that I work in, I work with students that can be anywhere between pre-primary up to grade 12. And we spend a lot of our time in schools doing programming, doing partnerships, and then of course doing case management from a social work perspective. So being within the schools, I've been with SchoolsPlus for 3 years now. Being in the school is something that I think that we have been noticing quite a lot with our students is the need for increased grief resources within our schools. So the school is the center of a child's life. They spend the majority of their time there through the week, through the school year. So accessing services through the school is very important because they're already here. They have the support around them from teachers, from SchoolsPlus, from school social work, psychologists, all of the support staff on site. So by having additional resources in the school available to our students, we can help students even more. Part of the reason I think that we need additional grief resources through the school is because all of our students have just gone through a global pandemic, which has changed the world as they know it. And most of us didn't have to live through a global pandemic when we were going through school. We just went through school, graduated, and went on with our lives. The kids are seeing right now that They might have had it one way and things are different now. So I think a lot of that, whether it's impacting them at home or it's impacting them elsewhere, we're seeing a lot of it at the school. We're seeing it through attendance, we're seeing it through behavior, we're seeing it just about every area. Kids are different than they were before the pandemic. So by having the additional grief resources, we can start to help kids with addressing the fact that not only did they go through a global pandemic, but we don't know how it affected them at home. Did they lose family members? Did they lose friends? Did they lose the neighbor down the street that they really liked? Did something happen to a teacher? All of this is coming up, and our kids are seeing more loss and grief as a result of COVID-19 than ever before. So by increasing the services, not just in the school, but in the community, and focusing on our kids more than ever, I think we can help them move past COVID-19 and move on with their lives. But not only is it going to help them, but it's going to help everyone in the community move past and accept the new reality that we have right now. So I'm hopeful that through my role with SchoolsPlus that we can start working on increased brief resources, reaching out to the IWK, working with Hospice Halifax, working with whoever we can, working with the Nova Scotia College of Social Workers to bring those resources to the schools, helping the admin staff and the teachers start working with our students with more of a trauma-informed perspective, and just helping the staff so that we can continue to help our students moving forward. So that would be my goal moving forward as a facilitator and as a social worker in the community. So thank you very much for listening to me, and thank you very much for inviting me to give my thoughts from the school perspective on this very important topic.
And you may or may not have seen this, but you can see it on our YouTube channel. At the National Child Day, which we partnered with the Healthy Populations Institute and IWK and the public libraries in Dalhousie, we asked kids what was the top issues, the top health concerns that they had, and mental health was the top concern. And the other issues around queer issues and microaggressions or racism were connected to mental health. So we know that our kids are saying that there's an increased need for support around mental health. And Kim wanted to share just one or two last thoughts on this topic.
Okay, so another element that I think is coming up a lot in the schools, and I'm hearing from students, and I'm reading through research right around the world, not just in our community, is the fact that during COVID, our kids were not going to school. So prior to that, kids often found that schools were their safe space. They had their support system, they had their friends, they had the social aspect. But then during COVID, schools were shut down and they were sent home to do virtual learning. So they lost the quote unquote safe spot. They didn't have their favorite teachers. They didn't have their favorite support staff. They didn't have their friends. We were telling kids, you can't be around each other because of COVID. Then coming back to school, unfortunately, it had kind of become, what I'm seeing anyway, is it had kind of become, school's no longer my complete safe space because it was taken away from me once. So if this happens again, I'm going to lose school again. So then what I'm finding is for some kids, it's kind of creating more of almost another grief process that they had lost school. They could potentially lose school again. So I think that is another element of the grief process in general for our students right now.
Thank you so much. Flo from Bereaved Families Cape Breton sent this video.
Hi, my name is Florence Fogarty. I am the Program Administrator for Bereaved Families of Nova Scotia. Today, I would like to take this opportunity to provide an overview of our organization as well as the programs and services we provide throughout Nova Scotia. Bereaved Families was first established in Cape Breton in 1990 as a grassroots organization. The organization is recognized in Nova Scotia as one of the oldest not-for-profit organizations providing bereavement support within the communities. The organization has touched the lives of 1,000 individuals in Cape Breton and beyond, and we are now happy to say we continue to help support grief within the communities throughout Nova Scotia. Bereaved Families is guided by a dedicated board of directors, a project lead, as well as a passionate team of both employees and volunteers. Our mission is to help as many people as possible who are grieving. And to do this, we continue to provide programs and services to help individuals cope with the loss and grief as a result of the death of someone they loved. We envision a society where support is readily available for persons grieving the loss of their loved one. We do understand that losing a loved one is a very difficult experience, so our goal is to provide individuals with innovative support and resources needed to navigate through the grief. And we want this to be no cost to the individual.
Right. Definitely needing to think about what resources are affordable and accessible in different parts of our province. And now we're going to have a chance to hear from Hallie.
Hello. So yeah, my name is Hallie Burt. My pronouns are she and her. And I'm currently a Master's of Social Work student with Phoenix Youth and Family Therapy. So today I just wanted to share a little bit about the program and the type of work that we do around grief. I'll start by just saying Phoenix Youth and Family Therapy is an early intervention program. We serve youth ages 11 to 24, and we'll work with individual youth and we'll work with families. One of the main approaches that we use is narrative therapy. So I wanted to speak a little to that and how it can be a really beautiful way to approach death, dying, and grief. Because narrative therapy really draws on how our relationships and the stories around our relationships kind of shape who we are and our identity. And so in that way, we can continue to have a relationship with a person who is no longer breathing, and we can continue to consult with that person and have them shape who we are throughout our life, even once they have died. And there's a narrative therapist from Denmark. Her name is Helena Grau. I think I pronounced her name correctly. I hope so. And she talks really beautifully about using narrative therapy around grief. And she really emphasizes, you know, kind of keeping this bond with the person. And she also talks about how what we might say is complicated grief is actually the result of how our society pathologizes grief, how there's these stages and you're supposed to move on and you're not supposed to talk about it, and there's a lot of repression, and that how that can be so distressing and painful for someone who wants to just talk about that person that they care about and they love and is a huge part of who they are. So with kind of that in mind, I just wanted to share a couple client stories that kind of show how we weave in these approaches and meet people where they're at. And both clients gave permission to share their stories. The first is Jimmy, and he worked with us when he was a caregiver for his mom when she was ill. And he kind of identified during therapy that he had really repressed, you know, his experiences and his feelings and how much that had impacted his life to do that. So he kind of learned how to validate his experiences and his emotions and to express them. So when his mom did pass away, he prioritized that. He knew he didn't want to hold it in like he had done in the past. He wanted to be able to validate his experiences, talk about them, express his feelings around it, talk about his mom. And something really beautiful that he said, I didn't work with him, but what I was told he said is he wanted to be really gentle with himself, which I thought was beautiful. And the other client was a younger client, and oftentimes, not just for children, but often for children, it's harder to like verbally articulate what they're going through or their stories. So the therapist worked on a tree of life exercise with this young person, which is a narrative exercise. And so they painted a tree, and then different parts of the tree represent different parts of this person's life and story. So, you know, where they came from, the important people in their life, their skills and talents and gifts, the things that they've overcome and where they want to go. And in doing that process, she remarked at how many people in her life loved and cared about her, even if they're no longer here. And the therapist also suggested that she talk to her dad's, I don't know if I mentioned, but her dad had passed away. That's an important part of me sharing this story. And so the therapist suggested that she talk to dad's friends and family members to get stories about dad. And something that she learned was that her dad was someone who stood up for others. And she kind of remarked, like, that's just like me, like I do that too. And so she was able to sort of like have this shared thing with her dad that she could carry with her. This was a part of her dad that she'll always have, that she can carry through. So these are just like little things, ways that we work with young people around grief. And we do other things like creating memory boxes, or maybe painting a stone that represents their loved one, or creating a bracelet and they can carry that person with them. And obviously there's so many ways that grief can come up for people, and but that's just kind of like one part of the picture that I wanted to share. And yeah, I think I'll just end with saying, kind of highlighting the importance of an early intervention type of service and free family therapy made available to folks. So, I mean, we know from research that basically grief and loss can really impact kids and everyone and their mental health, like increased depression, anxiety, low self-esteem, or less hope for the future. So in that way, therapy can be really beneficial. And another piece of that is that parents sometimes really struggle in how to support their young person because of those societal ways that we've traditionally dealt with grief, or because they themselves are experiencing the same loss. And so that's also why the family work is so important sometimes. And we do notice that we've seen an increase in family work, and we have fostered sort of a relationship with Hospice Halifax. So we will get referrals for youth from there, and then that often turns into family therapy. Yeah, those are the pieces I wanted to touch on today, and I just wanted to thank you. I'm really grateful to be part of this panel.
Thank you so very much, Hallie. Very grateful to you for sharing some of this with us, and we are going to have a chance to hear from Louise from Hospice Halifax in a second. If they can turn their camera on, there you are. And I will say that for those of you who don't know, I worked for a long time in palliative care and hospice. It's been always one of my big loves. And the first thing I did when I came here to unceded Mi'kmaq is I reached out to Hospice Halifax. I was like, where's the hospice work? This is my big love. And in large part because I think it is very much prevention work, as I think Hallie said very beautifully. And unfortunately, the hospice and palliative care is not as developed here as it has been in other places where I've lived and worked. But hopefully today's panel will help us change that as we continue to advocate for more grief support. So Louise, welcome. Thank you so much for sharing.
Thank you for having me. I just want to start by saying thank you to all of the speakers who've come before me. I've been sitting here really in awe of your vulnerability. So my name is Louise Jones, and I'm joining you today from Egypta. And my pronouns are she, her. I'm also of settler ancestry, and I was raised in rural Northern Ontario. And I think it's really important to locate myself in my work, especially because I'm often a person with a little more privilege in this space because I am of settler ancestry or things like that, right? And currently I'm the support services manager at Hospice Halifax. So that means in addition to being the social worker for our patients and families and residents, I manage our community grief counseling program and our team of support service professionals. And my intention for sharing this next bit with you is because I think we need visions of how death and dying could be. And so Hospice Halifax is an intentionally compassionate organization. It's a not-for-profit with the mission of providing the best end-of-life care possible. So what that means for us is that we have 10 private rooms, as well as spaces for families, chosen families, friends, and loved ones to gather, sleep, eat, and live. You know, on the weekend, we had 20 family members here for one person, and that's okay. This happens all the time. We often say we give you space to live before you die. We never charge for any of our programs, either in-house or in the community. And I know we're some of the few who do that. So we offer that 24-hour nursing care, dedicated physicians, social work, music therapy, counseling, and we maintain a large and diverse spiritual care network to tend to as many needs as we can. We always miss things here and there, but we do whatever we can. And we try to make folks feel at home. Pets are welcome, family dinners are hosted all the time, family can stay in the room with the person or in our guest room. And we've supported all kinds of moments family members and patients have asked for, from having horses visit to getting married to having the family baby shower here and everything in between. And what I'm going to ask you to do is hold an image of a space like that in your mind, a space where you get to be exactly who you are while you're dying. Like I said, we try for that all the time. Whether we get there all the time is something you should ask our patients and not us. But we've served over 540 patients since we've opened. And so I'm going to use the year 2022 to 2023. So April 1st, 2022 to March 31st, 2023. And I'm going to use those numbers because I think it's important we add a little bit of number context to everyone's feeling here. We served 116 patients during that time. But despite these numbers, we face a consistently large wait list. So while we were serving 116 patients, 137 did not make it here. They died on our wait list. And our wait list is always large, 60 to 70 people at a time. This is always on my mind. It's something I worry about a lot. And we have a need for more dedicated space for dying in Nova Scotia, whether that's in a facility, a hospice, a home of the person, it's necessary. And it's also really, really important that people get to die in and integrated in their communities. Hospice Halifax is located in the south end of Halifax, which historically is not everybody's home base in this city and in this province. And so we need spaces like this all over. You should be able to go down the street or around the corner and find a space where people are being supported in this way, wherever you are. And the reality is, too, our community counseling program, while beautiful, and one of the few in the province that is this low barrier and this free, because we don't ask for a health card. We just need a name and a date of birth. And that's a chosen name, by the way. And, you know, our groups in that same year I talked about were accessed 311 times. We provided 628 individual counseling sessions during that time. But we always had a wait list. And many people who couldn't make it to our location or couldn't access us virtually. And so we weren't able to serve. We also had to serve only short term. So again, people are not maybe getting the breadth and depth of service that they might need or want. And so we're really, we're doing what we can, but we need more spaces like this. We also can always better our own space. And the reality is we need that dedicated funding. We need dedicated resources. We don't just need to optimize our healthcare system. We really need to revolutionize it. It's not working for our population. We hear these stories all the time. That's no fault really necessarily of the staff who are on that front line all the time, but the system has not been set up to serve everyone, and it's not been set up to serve everyone comfortably. So the thing that I'm going to ask you to do is hold that vision of in your mind of how you would want to die, how you want your loved one to die. Of gospel music happening in the ICU, as Hallie shared with us, as Jacklyn shared, of having all of your loved ones, chosen and blood, around you. Imagine that, and then start thinking about how can we advocate for that in this province? What do we need to fight for, to ask for, to protest for, to demand? Because to die well and with dignity is a human right, and it's not a right accessible to everybody in our space. So I'm going to close there and just say that this comes from both professional and personal experience, and I'm with you. I've had the family members and loved ones in spaces they should never have been, and I've had them in good spaces as well. And I wish for all of you a much better death than some of the ones that we've all had to witness. Thank you, and miigwech, and merci. Vous pouvez aussi me demander des questions en français. Je vais vous répondre du mieux que je peux.
Parfait, merci beaucoup. We are so grateful, Ellen, to you for that important awareness and advocacy. And when I think of advocacy around grief, I don't think any of us can think of that without thinking of Serena. So we're very honored to have Serena here for all that you have been doing to advocate for grief services in unceded Mi'kmaq, and for everything that you have done personally. We are grateful. Thank you for sharing some of your perspective with us.
Thank you, Nash. It's wonderful to be here with all of you, and such a powerful commentary. I've been making notes everywhere. So thank you again to the speakers that have shed such light. And I guess today I think about the universality of the issue, and I was really excited about coming to a Big Ideas platform, but I want to be really honest about some of my own internal conundrum with this as well. So this is Big Ideas in mental health, but I often wonder, does grief belong in mental health? So looking for all kinds of audience participation in the chat. Tell me more. I'm not sure that it belongs in mental health. I'm not sure that it belongs in palliative care. I think it belongs everywhere. And I think that's part of the issue. I think that we need to come together. So thinking today about the excitement of the time in our province where we have had a commitment of federal funding to move the dial on grief and bereavement, on death and dying, I think this is both a really beautiful opportunity, but also one that I pay great attention to. Where are we going with this? So, you know, I would think that we've heard this, that death can be beautiful. And I've been an honored professional and personal person who can stand beside and know that I have witnessed some very beautiful dying experiences. But dying can also be complex. It can be difficult, and it can be traumatic. And I think we can't miss out on those opportunities about really thinking about where we're going with death, dying, and grief across our province. In this moment, I was jotting some notes thinking about there's currently, and there's more, but 4 major inquiries. And I want to pay heed and attention to those people today that are bearing witness again in the Desmond family inquiry and the tragedy in this part of the province. I think about murdered and missing Indigenous women. I think about our movement in truth and reconciliation, and I think about our mass casualty. We have to remember that death sometimes is incredibly traumatic. And our services need to keep working towards meeting people where they're at, no matter how complicated. So what I once believed, you know, it does have a touch point in palliative care. And Mary Ellen, I so eloquently believe, again, that we do need a revolution right now, more than ever. We somehow knew that prenatal care became really super important in our culture and our society. We knew that we had to really meet people where they were at as we were birthing or grieving children. We also need to do this in a prefatal lens. And we need to pay attention to the literacy, the awareness, the support, the education, and how do we meet people where they are and what they need. So I think about across the province, are the services the same? Are they different? Are we looking for universality, or are we remembering big C culture and small c culture in meaning regional disparities, cultural disparities in the way that resources are provided? I think about people dying in homeless shelters or not even making it to shelter in our province. I think about every ICU, every school system, every long-term care facility in this province. I think about hospitals, and I mean every department of the hospital. Some have the benefit of having palliative care units that are staffed with appropriate educated people. Some are not there yet. I think about our hospice movement, and I think about their wait lists. I think it's important in every facet from a social work lens that we think about how, and somebody talked to me today about this notion of tilling our soil. And I thought, what a Nova Scotia thing to think about from an agriculture lens. And I think it is time to till the soil. It's time to really reflect upon how our services move forward. And I would propose that grief needs to be a standalone. I don't think we put it in big ideas with mental health. I think it needs its own identity. I think being able to talk about death and dying in all kinds of ways, from our medical assistance, for the policies that are changing faster than what our families are getting the support for in this province. I think these are all components. So what I would also say, as I want to close, recognizing that again, I think it's important that we need to integrate death, dying, and grief in everything we do, community, family, individual. But I also think we need a deeply intentional intersectional lens to the way people live and honor the way that they die. Thank you.
Thank you so very much to you and to everyone who was part of our panel. This panel, this Big Ideas panel, is intended to advocate for a change in the way we are talking about health, around the ways we're talking about mental health, and looking at the unaddressed current methods of dealing with that. This is a time now for questions and comments. I know we've been having some comments and questions in the chat, and it can be for any of our speakers if they want to reflect on something that they've heard. One of the questions that was posed has to do with barriers to accessing palliative care or grief support. What are the different barriers? I think we talked a little bit about some of them already, in terms of literacy, in terms of access, in terms of cultural competence, in terms of the inequity of services. So what exists in Kijapuktuk, otherwise known as Halifax by a colonial name, or what exists across the rest of unceded Mi'kmaq or Nova Scotia? What are the different options and resources and obstacles that people have? So I'm opening it up to our speakers with deep gratitude to you all for your comments. If there's anything that you have that you would like to share, and there's also some great conversation in the chat. that where there's this idea of how there isn't anyone who doesn't have grief. So that goes back to what Serena was saying, and that it is something that needs to be, we need to rethink the way we think of mental health. We need to rethink the way we think of healthcare more broadly. So the palliative care and hospice approach is person-centered in the community, helping people focus on quality of life. It's a very different interprofessional, person-centered approach to healthcare, as opposed to even the ways in which it's medicalized and pathologized. So I'm opening it up to our panelists. If you want to turn on your camera and make a few comments, Louise, thank you so much.
So what I do want to say in terms of the barriers, we have talked a lot about them, and cultural competency is a big one. So is location. Another really simple factor is that most counseling services are not provided outside of urban centers. And I include small urban centers in that. And so folks who are living more rural and may have patchy internet access or difficulty with technology because of age or stage of life are really affected by that. So we run into that issue all the time, right? Just digital access and digital availability is not really enough. We need in-person supports where people are.
Thank you so much. I appreciate your sharing, and hope that if any of our other panelists have anything that they would like to say as we continue to advocate and really rethink the way we're even talking about mental health. That is part of that is rethinking the way our systems are currently set up and the ways in which certain things are labeled and sometimes pathologized. Serena, you spoke beautifully and powerfully, and would love to have you help us rethink this towards the revolution that Mary Ellen described earlier.
I so appreciate the comments here that it is embedded definitely in mental health, and I didn't want to come across that it shouldn't be there, but I often think that it's deeply embedded in every system in which we meet people. And I think about our, community services, all aspects. And I think if we had that deep embedding in all systems that we work, it's just, I think, again, it has an identity of its own. Back to the question that you had asked, Naj, I think it's really thinking about the variety of styles of grieving too, that not everyone needs a grief counselor. And we need to be really conscientious of that. The two-eyed seeing approach, about really thinking about the different approaches of how we work with grief. So I often come back to those styles of grieving. Intuitive may want to sit and talk, but there's certainly room for choirs and gospel singing and that instrumental grief that can really be so profound in our society. About some of the horticulture and equine therapies and things and different ways that we can meet people and experience grief that doesn't feel quite so kind of counselor person. I think, again, we need to be really creative. And to me, that this is a wonderful opportunity when we have dialogues like this to start to create a revolution that maybe has creativity and diversity at the core.
Thank you very much. Definitely appreciate that, and appreciate everyone's perspective on how we think about grief, death, and dying. Hallie, thank you so much for being willing to share.
Hopefully I'm going to make some sense now, but
you made some sense.
No, I'm joking. So I was just thinking about, how mental health always seems to be isolated, and I don't really think you can isolate it. I think it has to be connected to everything, spirituality and whatnot, because when I think of health, when I think of mental health, I don't think it as in isolation. I think about spiritual health. I think about, I think about the medicine wheel. I think about multiple ways of knowing, doing, and being, and understanding. And so I I think to stick something in mental health and say it only affects that one aspect, I think it's doing a disservice to, you know, cultures that maybe take the holistic approach. And, you know, I just don't think of mental health. I just have a problem with that. Even though I didn't work with Canadian mental health, I still think it needs to maybe have a name change. You know, just saying that I think of things such as service user directed or client directed rather than centered, because I don't really even know what that means. I mean, I know what it means, but to me, take the clue from the person who has that experience rather than saying, okay, we're gonna have that person in the middle and we're gonna have all the other people there. So maybe they don't want that. Maybe they want one person from there. Maybe they want two, maybe they want none. So yes, I too believe in the two-eyed seeing eptimuntuk approach. Just wanted to add that. Thank you. And just want to add from earlier, when I was talking about my mom, to talk about my mom earlier in her life, and she said one time after my grandfather had passed that, you know, I was in his room sleeping, and the next day there was this huge black fly, and I had a fly swatter and I was about to kill it. And my mom said, "No, that's your grandfather." Well, I was stunned, right? Because in the Black culture, she was telling me that the embodiment of your loved one that comes back, they come in multiple different ways. So that's why, you know, sometimes when I see a hugely big fly or something, maybe I'll start talking, then automatically, if there's no context and culture in there, somebody might think, oh, mental health, right? I think we need to think bigger. And that's just one example of your loved ones coming back to say, I'm safe, I got to the journey, and things continue from there. I just have a lot of thoughts in my head right now, so I thought I'd share that. Hopefully it's coming out clarity the way I want it to be. Thank you all very much for your insights.
Thank you so very much. And so grateful for the focus on this conversation. There's also been a question in the chat about how do we gain more training or awareness. We are certainly advocating for more interprofessional education. We're going to be having actually a 4-part series that'll be starting February 8th on interprofessional education. It is worth noting that Nova Scotia Health recently decided to stop funding clinical pastoral education, which is to say the intercultural, interreligious training for spiritual care. And we heard many of our panelists talk about how death and dying is a spiritual experience. And so we see that some of the funding decisions are actually going in the other direction, because chaplains are usually the ones that actually advocate for Indigenous communities or diverse communities have access to their religious and cultural traditions. So hopefully this panel will help raise awareness on why we need to be investing more in education and training for people who are working with grief or death and dying, to rethink the way we are talking about this and structuring this. But there's definitely a lot more work that needs to be done, because it does seem like in some ways the province is going in a different direction, while on the other hand, we have more need for it, especially since some of the more recent traumas that our province has experienced. Jocelyne, I see that you have unmuted, so or opened your camera, so I'm going to invite you to share some thoughts.
There's two things that I think of in response to your questions I'm led to share. I don't know exactly how they connect, but one is that I remind myself that humans are, although grief is often, it can certainly be the most difficult human experience that there is, that humans are by and large very resilient in the face of grief, and it really does look different for everyone, but I guess there's that one piece of like, that gives me hope in my own life to believe in resiliency in the face of life-changing grief and loss. So that's one thing I think of. And a specific tool that comes to my mind that I often will pull out when healthcare providers are asking for, what kind of, sometimes people will come to me and ask like what magic thing there is, how I can grief them, or, that I can be a grief wizard. And I cannot be a grief wizard. There is no grief wizard. Dr. Tachelle Bourdaire, who I really respect, and I had the opportunity for a brief moment to sit beside her. I was quite like a fangirl. Anyways, you can look her up, but she created for an academic setting the SHED tools. I can't remember what they stand for, but if you look it up, SHED tools, it's a way of suggestions for what to say and what not to say in the face of grief. She designed it in an academic context for university students, but I've taken the questions and kind of made ones more for healthcare, and it can be taken for any life context. So I just put that out there. If you Google SHED tools, Dr. Tachelle Bourdaire, you will find perhaps something useful to you in your practice in your life.
Thank you so very much. Very much appreciate that, and very much appreciate everyone's joining us to help us begin to reflect on the need for different ways of thinking about death and dying here in unceded Mi'kma'ki, to look at how we integrate grief support, bereavement. It's really part of what we started with, this notion of how do we decolonize healthcare, this notion that bodies, minds, hearts, spirits, cultural, community, health, that these are all separate. That's what really was at the heart of our repositioning report, is recognizing that when staff are being asked to be split and are not addressing the deeper grief issues, that they're burning out, and that this is at the core of a lot of our health system as it currently stands, so siloed and pathologizing. And so hopefully we can continue to advocate for more grief support funding, a focus on universal mental health care, a focus on how do we work to decolonize the way we're taking care of death and dying now, to look at it from a prevention perspective. I'm so grateful to all of our speakers for sharing of their wisdom, and to all of you for joining us. We are very grateful to you for helping us raise more awareness around this issue. And certainly there's a need for much more knowledge and skills amongst not just social workers, but healthcare providers and the world more broadly, as we talk about this issue. So, and there's some great resources being shared about SHED, grief tools, surviving healing, evolving through death and loss, content created by Dr. Tachelle Bourdaire. And feel free to continue sharing in the chat. But with that, thank you so much to everyone for joining us on this special day that hopefully will help us begin a new process of thinking about death and dying in Mi'kma'ki and beyond. Thank you all.